The first family we want to talk about are the macrolides. This group of antibiotics is commonly given to people who have some upper respiratory infections. They may have, say, some cellulitis in the tissue in their lower extremities. I often have personally seen this given for treatment of STIs. What's great about it is it's broad spectrum, so you don't exactly have to know what organism you need to treat because it kills a variety of them. In fact, it kills most gram-positive and some gram-negative bacteria. So you're going to see this one often given, and I'll give you some examples of what type of antibiotic is under the macrolide family. If we give it just in low doses, they call it bacteriostatic. Higher doses, bactericidal, so it actually causes more harm to more bacteria here. Here it just kind of maintains the status quo. You can give it PO or IV, not IM. If you're going to administer the macrolides IV, you definitely want to watch and make sure they're not developing phlebitis, which is what you see here, inflammation of the veins. And if you were to feel those, they would be hard as rocks. And to treat this, you would stop your IV, probably have to switch IV sites. This isn't, meaning that the person's allergic to it and can't have it again. It just means that the veins are reacting because the medicine's been given too fast. So warm compresses for somebody who has this, and it'll go away soon. Okay, so this family of drugs are the gold standard for treating mycoplasmal pneumonia and Legionnaire's disease. So if you have those two diagnoses, you're probably going to see a macrolide administered. The most popular one is erythromycin. I don't have it listed on here, but you'll see erythromycin ordered to treat those two diseases. You're also going to see azithromycin. Many of you probably have taken azithromycin yourself. The brand name for this one is Z-Pak, if you have an upper respiratory infection or URI. So anyway, they also give this one for uncomplicated skin infection, so doesn't involve the bone, it's just something on the surface, and they'll give you this. With this drug, or with this family of drugs, erythromycin, azithromycin, you need to watch for tinnitus and ototoxicity. So they start not being able to hear you in whatever you're trying to tell them, or if they experience ringing in the ears and they're on this drug, it needs to be stopped. Very commonly, you'll have nausea, vomiting, diarrhea, unfortunately, and that can be managed by switching to a different antibiotic. And we define diarrhea by greater than 3 watery stools per day. So if they're under that number, it's okay. They can continue taking this antibiotic. 3 is your magic number. For hepatotoxicity, this drug is generally safe. However, if they start taking, say, Lortab, which has acetaminophen in it, or if they are on a phenothiazine, which is like for schizophrenia and such, and also sulfonamides, we'll talk about those later, they probably are increasing their risk for having liver failure. So you have to kind of do one or the other, not both. We also want to be careful if our person is taking Coumadin here, theophylline, or carbamazepine. The other name for that one is Tegretol, and if you remember, this one is given for seizures. If we have a patient that is taking the macrolides and on this drug, these are going to increase. So our person's going to bleed more, they're going to have more cardiac side effects, and they may have more sedation from this being too much in their system. And can also flip the other way, where if we have patients on diflucan and this Nizoral, the erythromycin level will actually increase. And so we got to do peaks and troughs on this person and make sure their kidneys are okay if they're on them together. We don't want our person to be on azithromycin and taking antacids at the same time, just because the azithromycin won't be able to absorb. So we're going to ask the patient a few things on our assessment, such as what drugs are you taking? If they take an antacid, we need to give them a heads up about making sure they take the antacid a separate time from the antibiotic. Baseline values, we're looking to see if they have liver dysfunction. If they do have liver dysfunction, they probably don't need to be on this medication just because it puts a lot of pressure on the liver to do its job. It won't probably do it well. So another thing you can get is, when I say baseline values, get their liver enzymes, get their ALT, the SGOT, all of those, make sure they're normal and regulate them that they stay normal and not start increasing. In fact, here we have somebody who is jaundice from after being on this drugs for too long. It just hurt their liver. For nursing diagnosis, how about risk for infection? That one's kind of a possible one, kind of a given anytime anybody's on an antibiotic. We also have risk for impaired tissue integrity, and the reason for that one is because if you're on azithromycin, you can have some diarrhea, and so their tissue integrity down there is at risk for being compromised just because of the diarrhea. So we plan that they are going to have absence of infection, and for nursing interventions, always check the culture sensitivity of whatever infection source it is before starting therapy, not afterward. Let's see. Remind your patient they need to take every last pill, even if they're feeling well, just continue to take them. Reason being is this decreases bacterial resistance, that they will mutate. We want those drugs to remain effective, so the person has to take everything. If they do take antacids, 2 hours before, 2 hours after. Okay. This person also needs to make sure that they drink the medicine with a full glass of water. And evaluate, if they've got a decrease in or absence of infection. White blood cells are returned to normal, all that good stuff. Compliance is key, though. Remember that one for this. Let's see if I want to tell you anything else. These can sometimes cause the super infection to develop. That's whenever it kills off the good bacteria. So monitor your person for stomatitis and vaginitis as well. All right, let's keep moving. Since we were talking about tetracyclines, I'm just going to segue right into the whole category of tetracyclines. So very common. In fact, you'll see these a lot in the outpatient setting because they're very well tolerated and don't need much monitoring, and because they're given in, depends if they're given short-term or long-term. But if somebody has tick bite, we can go ahead and probably give them some tetracycline, and it will do the job. Tetracyclines are also great because they treat acne, and people who have GERD, which is due to the Helicobacter pylori, little spirochete. It does a great job eradicating that. Also, as well as some positive and negative, or gram-positive and gram-negative bacteria. It is considered broad spectrum, so it kills a lot of things. In your world, when you hear broad spectrum, think supra-infection. Tie those two together. If we kill off all the bacteria, some of that bacteria was good, and now we're going to have a risk for yeast infections and vaginal infections and thrush, yada yada. We can give it a couple different routes. I will say that the IM is rarely used because it is very painful and causes a lot of tissue irritation. So if you can get it to the patient through the oral route or IV route, that is the best way to go. Next. Okay, some of the things that happen. This person, if they get in the sun and they're on this drug, they're going to look like a little crispy critter. So make sure this person is well aware of the photosensitivity that can develop or happen when they're on tetracycline. So warn them of this. If your child, or if you're a mother and you take this drug, you cannot take it in the first trimester, I believe. I saw that somewhere. Cannot take this in the first trimester or the third trimester. So, reason being for the first trimester, they say that it, I know I have it somewhere. Yes, okay, I see it here. Because it has possible teratogenic effects on the baby, or, the fetus. For women in the last trimester of pregnancy, they also shouldn't take this, take this classification of drugs, because it will actually cause permanent staining of the baby's teeth. So even though the baby doesn't have any teeth, they will have permanently stained teeth. And children younger than 8 years old cannot take this. So when those adult teeth grow in, they will be permanently stained. I should show y'all a picture. Oh yeah, we'll get there. Always a risk for pseudomembranous colitis. That's because this is a broad spectrum. It can also cause some blood dyscrasias. It does also have some side effects of nephrotoxicity. However, generally these are very safe drugs. We just need to make sure that the BUN creatinine is not already elevated. So they have short-term and long-term drugs. I personally have often seen the long-term drugs, and they're given, I believe, once or twice a day, the doxycycline and the minocycline. Let me separate the short from the long for you. These can be given with milk, and it is preferred actually that they're given with milk and with food to decrease gastric upset and to help the medicine get absorbed. However, short-term and intermediate, you do not give with milk or food. In fact, you need to space it out, generally 1 hour before or 2 hours after taking any kind of calcium supplements or milk or anything of that nature. So make sure that you remember there's a difference in when you can take it with food and with milk. Okay? This was referring to the short and the intermediate. Also, you know that tetracyclines can be teratogenic. It can also decrease the effectiveness of oral contraceptives. So you have somebody who, may be on tetracycline, or I should, be specific, on doxycycline for their acne, because it does do a great job. It's a bacteriostatic, helps decrease the number of breakouts that somebody has. If that person is sexually active and thinks they're okay, if they just take the, doxycycline because they're on their Yaz or whatever kind of pills, oral contraceptive that they take, not good. They need to have an extra protective method of contraception, and it's real important that they understand that there is a possibility of having, a teratogenic effect once they're on the doxycycline. See if there's anything else I want to tell you about this. I think that's it. I will say that the tetracyclines do a very good job controlling acne and cystic acne, in case you're interested for yourself. These are typical. In fact, I feel like I pull these out for most antibiotics. Make sure you check, culture and sensitivity before the drug. This is not particularly talking about acne. This is if somebody has another skin or abdominal wound, which is generally why you give tetracyclines. Watch the meal time. If it's a short or intermediate tetracycline, watch the kidney, liver function. And it's very important, I'm glad this is, remember this, make sure that these drugs are given when they are not fresh, fresh off the press, but they're not expired. Reason being is that a dangerous intoxic metabolite is, produced whenever the drugs sit for long periods of time and they're exposed to the heat. So it's very important that these drugs stay out of the light and they're not expired. And we talked about the photosensitivity. Can't remember why I have oral hygiene in there. Actually, I do remember we had a guy on vibromycin, which is also known as doxycycline. Really interesting. Came in because he was bitten by a crab. Actually, he was pulling crabs out of his little crab cage, and a crab pinched him. And it's been known that these shellfish, whether it's a crab or oyster, have these type of bacterias living on the outside of their shell. And when it pinched him, it broke his skin integrity. And he said within 12 hours his hand went all swollen. It was red. In fact, we had to do an immediate or emergency incision and drainage on it, and try to debride all of the tissue, because it was actually turning necrotic within 12 hours. And I administered him the fibromycin, and he said within 24 hours after administration of the tetracycline, it looked like his normal hand, not like a claw hand. No, I don't know, just a little story. Amazing of drugs. The other, a family member, I should say, of the tetracyclines is the glycyclines. The only drug in this category known is Tigestyl. It's a very expensive drug, but if you do have a complicated skin infection, say a chronic PVD ulcer or chronic peripheral arterial disease ulcer, even some abdominal infections, they'll go ahead and administer the Tigestyl. And you will want to treat this drug very similar to the other ones, the tetracycline group. It's just kind of a cousin of it. This is one of those antibiotic groups that we just have to throw in there at you, but I promise I am going to correlate it. Peptides, polymyxin B, bacitracin, do those ring a bell? Think over the counter, think triple antibiotic ointment. Yes, in fact, at one point in your life, you probably had a peptide applied to, some kind of skin abrasion that you had. That is actually one of the number one reasons that we use the peptide group of antibiotics, because it's a topical ointment for skin infections. A lot of times we just apply it to prevent. In fact, nowadays they're actually recommending that for any kind of incision or wound, clean it real good with soap and water and leave it alone. When it's infected, then you apply this. So they're actually getting away from the idea of using the peptides prophylactically. However, in the hospital, I have seen doctors still use it if the person's at high risk for developing infection. So just kind of keep that in the back of your mind, but no longer for prophylactic use. We can also use peptides, the polymyxin B or the bacitracin, for eye ointments. If they have an eye infection, they will probably get a version of polymyxin B. The route, I don't have ophthalmic written down here, but it can be eye, and if you do give it IV, you have to give it very slowly. Let's see. One of the side effects of these drugs is neurotoxicity, so they will start getting paresthesias in their hands and their toes, and if that were to occur, it's reversible if you stop the drug. So pins and needles, peptides, discontinue, stop. We don't exactly administer the polymyxin IV version of this drug really anymore, because it is extremely painful. In fact, if you get an order for administering polymyxin B IM, beg for the patient's sake. Don't think there's anything else I want to add on top of this. And as you can expect, it's an antibiotic, so what can possibly happen? A drug-induced dermatitis. So always watch your skin for rashes, for the person to develop, any kind of hives, and just be on guard on that. That goes with any antibiotic, okay? And the next group we have is the Lincosamides. So these are good in that they can be both bacteriostatic and bactericidal. Again, your most popular one that you're going to see is clindamycin. However, they do still on occasion order patients to have this lincomycin. It's not as popular, so when you think lincosamide, think clindamycin. And it is very good for anybody who has infection of staph. However, I will mention it is not effective against gram-negative bacteria, unlike our macrolide. This one doesn't do a thing for it. So if your person has E. coli, if your person has Proteus infection, or even Pseudomonas, they need to come off clindamycin because it does not do anything for them. Come on. Let's go ahead and do a practice question. Which teaching by the nurse has highest priority for the patient taking azithromycin? I'll give you a second to think. Okay, the answer is D. Instruct the patient to report any loose stools or diarrhea, which is greater than 3 times a day. Okay?
Alright, so let me get my pointer. There you are. When we talk about administering clindamycin, the first thing that should come to your mind is how bad is their diarrhea. Not so much if they have diarrhea, but how bad is it? It causes significant GI distress. In fact, patients normally report just pretty intense nausea. They may report vomiting, but diarrhea for sure. What's the problem with clindamycin is that it does a great job killing our infection. However, it does a great job killing that good bacteria that's in our colon. And when we have the good bacteria, being suppressed, the bad bacteria, there's that nice little homeostasis going on inside there. That bad bacteria will actually overgrow, and normally that bacteria is known as C. diff or Clostridium difficile. It's very, very often associated with the use of clindamycin when cases come in into the hospital. In fact, I spoke with a infectious disease doctor, Dr. Erickson, and he said you can almost closely guarantee if somebody has uncontrolled diarrhea after they stopped clindamycin, it's C. diff, and the clindamycin precipitated it. So we love you, clindamycin. We hate you, clindamycin. That's how I feel. How do you take it? You take it with a full glass of water. Don't worry about if you take it with food or without food, and just make sure the diarrhea doesn't happen, like it's not too severe. They're going to have it. Remember, they're going to get it, but too severe is a bad thing. Big thing I want to point out. Look, here we go. Another seizure medication. Always got a drug interaction with seizure medications. It's almost like a guarantee. Aminoglycosides are an extremely popular group of broad-spectrum antibiotics. They kill a lot of different things. They have a bactericidal effect, not so much a bacteriostatic. So it is, when we say in terms of is it a light antibiotic or a heavy antibiotic, meaning how hard is it on the body, I'm going to say it's a heavy one. Kills a lot of stuff, and it can do a lot of damage to the body in an effort to do good. If you notice, a lot of them have a very similar suffix here. Casein, mycin, mycin. These are also, they're really well known for being the mycins. For serious infections, such as skin infections, we also use them often to treat UTIs. The problem with this is if you give them PO, they're not exactly absorbed very well or at all from the from the GI tract. They can't cross into the system very well. If you have a GI problem, then you can give it to the GI system. But if you have a skin infection, you're more than likely going to be giving this IV. Looks like I got a little ahead of myself. As you can see here, more than likely you're going to be giving this IM or IV. Some oral though. That's just in case you have a bacteria in the bowel. Let's see. The main side effects I want you to think of are... let's see if I can get it to come with... There we go. Ototoxicity and nephrotoxicity. These are very, very important to remember when you think aminoglycosides. So we're going to be asking our patient, are you having any changes in your hearing? Or do you have any ringing in the ears? And for nephrotoxicity, this is extremely important to watch their urine output. Are they retaining fluids, such as, are they starting to swell up, get pitting edema? Do they have wetness in their lungs, such as rales or rhonchi? So be on the lookout for signs and symptoms of ototoxicity and nephrotoxicity. Lab-wise, what can you check to see if they have nephrotoxicity? I know you're thinking creatinine, BUN. Nice job, nice job. All of these aminoglycosides are heavily dependent upon the peak and the trough. This is where a pharmacist gets involved, and you will administer the antibiotic, and it takes a little bit, it gets in their system. We know that an estimated peak happens, and then it goes back down, and the pharmacist and or the doctor will ask you to draw a trough. They'll say, draw me a gentamicin trough or a amikacin trough. So you need to do it 30 minutes prior to the next dose. In general, hospitals say don't wait until the results have come back before you administer it. They say, go ahead, draw the trough, administer the drug. The pharmacist will review the trough, a few hours later and make adjustments to future doses. Let's just say your therapeutic level is too high. They'll say, okay, we're putting ourselves at risk for ototoxicity and nephrotoxicity. So the doc or pharmacist will reduce the dose. Let's see. The big thing on this one literally is just ototoxicity and nephrotoxicity. And they have a lot of IV interactions with a lot of IV fluids, so you got to check compatibility. And that goes for any time you take a medicine. You knew that though. I know. I kind of already hit that. The vitals, we should not be seeing any kind of hypertension. Hypertension would indicate a fluid volume overload. Urine output should be maintained. Got to check out the liver and BUN. Most importantly, though, the creatinine and BUN. So what's going to happen to our serum electrolytes if we get on aminoglycosides? You will see your mag and your potassium go down a little bit. So just kind of keep a lookout, make sure our mag and potassium don't go too low. It happens to some people, but generally it's well tolerated. Figure out somebody's baseline. If they have they're deaf in one ear, and then you give them this drug and you didn't assess it prior to, oh no, they can't hear, and you call the doctor, she's gonna maybe ask you, did you assess your patient prior to? So definitely assess what they are prior to. Okay. I think that might be it. Let's see. Just kidding. I said that was it. Got you. So for aminoglycosides, always before you administer, check the culture and sensitivity. That's a given before antibiotic if this is the first dose. If your person has less than 600 mils today, death will presume, no, not really death, just injury. So make sure your urine is about 600 mils a day. Compare yesterday's renal function to today's renal function. trends or where it's at, folks. There's a hearing loss again. Do you think I'm trying to tell you something? Maybe. Sunscreen, because if you go back a few slides, this is a drug that causes photosensitivity, so they're going to be more likely to burn. Ouch, that just hurts. Super infection, you're going to be, for females, checking to see if they have a vaginal yeast infection, looking inside their mouth. Do they have a furry tongue like thrush? And, if that's the case, a lot of times you have to give them like monostat or even nystatin to swish and swallow. Okay, you got your peak and troughs there. Okay, we're good on that one. Oh. And if you don't mind, please click this video here for a little breath of fresh air. That's it for right now.